everybody. Welcome to tonight's webinar. My name is Nicole Byram. I'm a registered dietitian with Celiac Canada, and I'm going to give you about 1 minute to get yourself settled and get a glass of water and sit down and get ready for a really exciting hour of the latest and greatest information on celiac disease with Dr. Ben Lebwohl, who I will introduce in a moment. But for now, if you get a chance, let us know in the chat where you're joining us from tonight, because I'm always interested to know where in Canada or elsewhere you are joining us from. So I am in North Vancouver in today, sunny BC. So let me know, hoping we span coast to coast. So Thunder Bay, Chatham, Kent, Ontario. Melissa. Hi, Melissa. Halton Hills, Regina, Guelph, Vancouver, St. John's. We did it coast to coast. Burlington, Ottawa, Salt Spring Island, gorgeous. Calgary, Dartmouth, Grand Prairie, London. Okay, we got lots. North Van, hey. Another North Vanner. All right, so I am going to get started. So before we begin, I'm going to give a land acknowledgement. So the land that I am on tonight is where I'm going to acknowledge, and I am on the traditional and unceded territories of the Coast Salish people, including the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And here we promise to learn, live, and share educational experiences on their traditional territory. And for that, we express our deep gratitude. So tonight we are talking, or this afternoon, we are talking about the latest and greatest in celiac research. So I'm going to introduce our esteemed speaker, and then I'm going to give you a little bit of housekeeping so everybody knows the rules of the game for tonight. So we are honored to be joined tonight by Dr. Ben Lebwohl, who's a graduate of Harvard College, and where he majored in music. He received his MD from Columbia College of Physicians and Surgeons in 2003, and then completed his internship, residency, and chief residency in internal medicine at Columbia. He stayed at Columbia as a fellow in digestive and liver disease, during which time he obtained a master's in patient-oriented research from the Department of Biostatistics at the Mailman School of Public Health. Dr. Lebwohl was a postdoctoral fellow at a National Cancer Institute-funded training program in cancer-related population sciences under the mentorship of Alfred Nugget. And he joined the faculty of Celiac Disease, the faculty of the Celiac Disease Center at Columbia University in 2010. Dr. Lebwohl is a former president of the Society for the Study of Celiac Disease and is the director of clinical research at the Celiac Disease Center in Columbia University, where he collaborates with investigators in the United States and abroad in epidemiology, patterns of care, natural history, and therapeutics. So with that, aren't we thrilled to have you here with us tonight? Because that is quite a mouthful, for sure. So a little bit of housekeeping for everybody just before we get started. The chat is just to let us know chat things, not for official questions. Please keep the chat respectful and kind. For official Q&As that we will be going through with Dr. Lebwohl after the presentation is completed, please put that in the Q&A box at the bottom of your screen. You will see along the tab for Q&A, that's where we will be collecting the questions. So we look forward to that time. And with no further ado, I don't want to take up any more time. I will pass you over to Dr. Lebwohl. Thanks so much.
Thank you, Nicole. And thank you to Celiac Canada. I think it's such a wonderful community that you have. It's humbling to be able to share some of my perspectives with this community of dedicated health professionals and individuals in the celiac disease community. What I'm going to be spending this time on is a recent publication. These are updated guidelines on the diagnosis and management of celiac disease. These are published by the American College of Gastroenterology, and these were published in the American Journal of Gastroenterology in January of 2023. So, I know latest and greatest is how this was billed. This is the latest. This is, refreshed, updated guidelines. In terms of greatest, I think it's a matter of opinion. Guidelines are always a matter of compromise and taking what we know from the evidence base, from the literature, and having to make decisions under the conditions of uncertainty. Guidelines tend to be on the conservative side. This is not sort of highly experimental, cutting edge stuff. We want to be confident that our recommendations have some evidence behind it and that it's sound. So I'd like to start by talking about the rationale for even publishing updated guidelines. The American College of Gastroenterology last published guidelines on celiac disease, as you can see in the arrow here, in 2013, so 10 years ago. A fair amount has happened between then and now with regard to the science, our understanding of celiac disease, natural history, and I'll be citing some of the studies that have happened between then and now, and some of the differences between those older guidelines and these recently published guidelines. So shown here are the 2023 guidelines that I was honored to be a part of. If you're interested in reading the whole thing, the references in the bottom of my screen, and also there's a QR code on the top right of this screen, and you can take a photo of that. It'll be on a couple of subsequent screens. This was not the doings of one person by any stretch of the imagination, and indeed, it really was a team effort. You can see the actual authors under the in the byline. And Alberto Rubio Tapia, who's the first author of this guideline, really did the lion's share of the work in terms of getting us all together, having to make some decisions about which subjects to tackle in this set of guidelines, moderating discussions, especially when there was disagreement, and doing the bulk of the writing of the manuscript and revision. And so he was really a great leader. He is based at the Cleveland Clinic in the United States. But you could see there's a number of other authors, including pediatric gastroenterologists, adult gastroenterologists. We also had grade methodologists on the author team, more on grade in a moment. Any guideline published by the American College of Gastroenterology has a guideline monitor as a representative, sort of a disinterested party by the organization. And we were fortunate to have the assistance of librarians who were instrumental in generating the literature review search. GRADE is an acronym that stands for the Grading of Recommendations, Assessment, Development, and Evaluation. You're going to be hearing a lot more about GRADE in the years to come as more guidelines come out, because it has really emerged as a rigorous way to generate guidelines. There have been guidelines for as long as there have been medical publications, really. And guidelines are a list of recommendations or suggestions. The question is, what are these based on? And GRADE is an attempt to make this based on something more than just expert opinion. The old, bunch of people sitting around a table or around a Zoom screen trying to decide what's best. Instead, there's a systematic review of the literature, and we actually grade the different studies so as to inform our recommendations. There is a standardized process, and it begins with the formulation of a clinical question. This is a so-called PICO question, which is a way to formulate a question about diagnosis or management that allows you to search in a systematic way and then find an answer. That then proceeds to literature review and certainty of the evidence. There are ratings that emerge out of this process. There is a matter of certainty. How certain are we of any given recommendation? And they range from very low to high. And the definitions are strict. If something is highly certain, that means that the guideline authors, have a lot of confidence that the true effect is estimated to the estimated effect, is similar to the estimated effect. What that means is the number or the result that we see in the paper is very highly likely to be true. Whereas if it's very low, the true effect is probably markedly different from the estimated effect. Many studies are somewhere in between very low and high. And we rate certainty based on these criteria that are listed on the left-hand column. How biased are we worried that the paper is? How inconsistent is it? How indirect? And then we can make something more certain if it's a very large effect or if we see a dose response. So we typically start at a certain level of certainty, and that will depend on what the style of the study was, the design of the study. A randomized trial certainly gives us a lot more certainty than an observational study, and then we can rate up or down. But we start with the so-called PICO question. PICO is an acronym where P is the population of interest, I is intervention, C is comparison group, and O is outcome of interest. And so we ask any question about celiac disease in the form of a PICO question, where we first have to know, who are we talking about? What is the intervention we're talking about as compared to what? And what is the outcome we're hoping to achieve or avoid? And so as an example, one key PICO question that we asked in this set of guidelines was, in adults and children with celiac disease, how is a combination of non-invasive serology test or blood tests alone compared to relying on a duodenal biopsy with regard to the confirmation of the diagnosis of celiac disease? That was a top PICO question that we asked. But in total, we actually asked 8 PICO questions. And I'll briefly go over them. The first one was the one I just mentioned about relying on blood tests to diagnose celiac disease. The next one was about looking at mucosal healing. Should we rely on mucosal healing with a follow-up biopsy in adults with celiac disease? What about gluten detection devices as compared to the current standard of care, which is monitoring with a dietitian to monitor adherence to the gluten-free diet? The fourth PICO question was, in patients with celiac disease, what is the effect of probiotics in addition to the gluten-free diet compared to the gluten-free diet alone? And there are 4 more. Number 5 was, among people with newly diagnosed celiac disease, is a diet with oats associated with clinical remission and mucosal healing compared to no oats? For patients with celiac disease, does the pneumococcal vaccine reduce the future risk of serious infection compared to not having the vaccine? The 7th was, should case finding versus mass screening be the way that we improve detection of celiac disease? And finally, specifically for children, should we be using the tissue transglutaminase together with the gliadin peptide in combination compared to TTG alone? And so we summarize these PICO questions in this table, in this guideline. I'm going to be discussing a subset, about 4 PICO questions from this guideline, but we will leave time for questions. And if you're interested in a summary of some of the other ones, we can go over that, or we can delve deeper into these. But this is, again, a big document that covers a lot of celiac related topics. So let's start with arguably the most important and headline grabbing one. Should a combination of non-invasive serology tests versus biopsy be used to confirm the diagnosis of celiac disease in adults and children? And so the first one in black here on top is the least controversial. We recommend EGD, that's esophagogastroduodenoscopy or upper endoscopy with multiple biopsies for confirmation of diagnosis in children and adults with suspicion of celiac disease. That is a strong recommendation. We believe in a biopsy. It's based on a moderate quality of evidence. But there are 2 other recommendations that are new in this version of the guidelines, new since 10 years ago. First, we suggest, not recommend, but suggest a combination of high-level TTG-IgA, that's a 10 times greater upper limit of normal, together with a positive endomysial antibody in a second blood sample as reliable tests for diagnosis of celiac disease in children. And then lastly, in symptomatic adults unwilling or unable to undergo upper endoscopy, the same criteria may be considered after the fact as a diagnosis of likely celiac disease. That's a conditional recommendation with a moderate quality of evidence. So the background here, as many of you may know, in Europe, they do things a little differently with regard to how celiac disease is diagnosed, at least in children. These guidelines have been present since 2012 and were updated most recently in 2020 by the European Society. It's called ESPGHAN. They allow for a biopsy-free pathway for children. And they require that the TTG, IgA, and the endomysial antibody be elevated. The TTG greater than 10 times upper limit of normal, and then a second draw, endomysial antibody being positive. They used to say this was only recommended in symptomatic children and not asymptomatic children, but now they are saying it is conditionally recommended in asymptomatic children as well. So this has really caught on in Europe, and yet up until the publication of these new guidelines by the ACG this year, there were no US guidelines that allowed for any biopsy-free pathway in the United States for adults or children. So what about adults? We have fewer data, fewer studies with regard to how accurate blood tests are in adults compared to children, particularly highly elevated blood tests. But emerging data suggests a high positive predictive value of a highly elevated TTG-IgA, but not quite as high as for children. In other words, if you've got a 10 times elevated TTG-IgA in an adult, it's not going to be 100% that this person has celiac disease. In children, at least by European data, it's pretty close to 100%. Not quite, but likely close to 99%. The data that we have for adults are limited, but here is one study that our center, Columbia, participated in. This was a multi-center study involving 8 countries, 11 endoscopy suites. And we had a number of patients who had a greater than 10-fold elevated TTG-IgA, which comprised about almost 1/3 of everyone who had an elevated antibody undergoing a biopsy. Of 42 patients, 40 had duodenal villus atrophy on their biopsy. In other words, 40 of them clearly had evidence of celiac disease when having a biopsy under a gluten-containing diet. That means that the positive predictive value, at least in this one study, was 95%. To me, I found this to be sort of a helpful study when talking to my patients. So we're 95% sure someone with that kind of elevation has celiac disease. So what do we do with that kind of data in the face of the fact that there's still substantial uncertainty about what 95% really means in terms of a lifelong need for a gluten-free diet, and also the fact that 95% is just one study's estimate and that might be adjusted up or down somewhat. We are still waiting on data. The question is, do we hold the line and say you must have a biopsy and until we wait for more data, or do we make a change now? So even though we are still waiting on data, I would say that the conversation that happened in this guideline generation was that we have to acknowledge that endoscopy might not always be practical. It might not always be safe in some scenarios. If you have an adult with major cardiovascular disease or a major bleeding risk, it might not be appropriate to subject them to a biopsy. It's also known that if someone comes in and they're already on a gluten-free diet, and some of those people, reintroducing gluten, putting them on a gluten challenge, can cause severe symptoms. It might not be advisable or tolerable by some. And if we hold the line and we say that you need a biopsy to be considered to have celiac disease, otherwise you're not sure to have celiac disease, we were worried that some patients will be left out of clinical trials of and of therapeutics, particularly. If a drug to treat celiac disease gets approved by the Food and Drug Administration, and it's for people with celiac disease, and you have someone who you're more than 95% sure has celiac disease, they might not have the opportunity to either be in a study of that drug or to have their insurance pay for that drug when it's approved. For that reason, we came up with this after the fact rubric. This allows us to separate out certain non-biopsied individuals as likely or even highly likely to have celiac disease. About 95% sure we've got celiac disease. I would point out these are stringent criteria. These are not loose. Very few people would meet this to have both a 10 times elevation of TTG plus a separate EMA. To have this after the fact is actually quite rare. And this is only being suggested in symptomatic individuals, not asymptomatic individuals. How this is going to play out, it's too early to say. These guidelines have only been on the books about 5 months. This is an incremental change. We are calling this a conditional recommendation. Conditional is a euphemism for weak. It is a weak recommendation. It's not based on strong data. It'll be most useful when we're really worried about biopsying someone, and that's a rare situation. It's less likely to apply in scenarios where the gluten-free diet has already begun, because most people will not meet those stringent criteria after the fact. We don't know what the consequences will be. It might lead to more biopsies because these criteria are so stringent, or it might lead to fewer biopsies because now some adults may opt to forego the biopsy given this after the fact conditional recommendation. So we'll leave that there. I imagine there'll be questions or comments, but let's move on to another topic very close to my heart. This is something that I've thought deeply about for many years and studied, which is about mucosal healing. The PICO question is, should intestinal mucosal healing versus clinical and serologic remission be used as a goal of gluten-free diet therapy to improve long-term outcomes, such as mortality, cancer risk, and osteoporosis in adults with celiac disease? In other words, should we bring people back for a repeat biopsy? And the recommendation is we suggest, not recommend, but suggest, so it's weaker, setting a goal of intestinal healing as an endpoint of gluten-free diet therapy. We advocate for individualized discussion of goals of the diet with the patient beyond clinical and serological remission. Again, conditional recommendation, that is to say weak, low quality of evidence. In the guideline, we talk about some key concepts. One of them, the top, applies to symptomatic patients. Upper endoscopy with intestinal biopsies is useful for monitoring in cases with a lack of clinical response or relapse of symptoms despite a gluten-free diet. But we also make this comment regarding asymptomatic people. Follow-up biopsy should be considered for assessment of mucosal healing in adults in the absence of symptoms after 2 years of starting a gluten-free diet, after shared decision-making between patient and provider. Now, how much of this is new? So I should say that if you go back to the 2013 guidelines, 10 years ago, in the recommendations, there are recommendations for symptomatic individuals. You can see it here. Upper endoscopy and biopsies is recommended for monitoring in cases with a lack of clinical response or a relapse. And then they also mention in the fine print of that 2013 guideline, they say it is reasonable to do a follow-up biopsy in adults after 2 years. So the current guidelines sort of bump it up from it is reasonable to a suggestion, and they say that it be discussed as shared decision-making. Just a little bit on the data that's emerged between 2013 and 2023. A lot of this work has come out of Sweden. I've had the honor of working with a group in Sweden on many of the questions relating to the clinical significance of ongoing damage, intestinal damage, and celiac disease. And shown here is a forest plot showing the increased risk, the hazard ratio for various outcomes. The outcomes are listed in the text, and the long numbers right next to each outcome is the PubMed identification. So if you plug that in to PubMed, which is our major database of papers, the specific paper comes out. You will notice that most of these horizontal lines are blue because most of the data comes out of Sweden. Very few come from elsewhere. There's one in this graph that comes from Italy, but this is the graph that shows outcomes that seem to be worse among people who fail to heal. Lymphoma, adenocarcinoma of the small intestines, so small bowel cancer, low bone density, and fracture. Those are the major things we worry about and that have been proven to be associated with ongoing intestinal damage. But that's not the whole story. There are some outcomes that are actually paradoxically associated in which if you heal, you're actually worse off. These are the 3 things we've found that are protective or that seem to be less likely to happen among people with ongoing damage. For some reason, an epilepsy diagnosis, we have no idea why. Breast cancer risk seems to be lower in people who fail to heal. We've got some theories about that. We can get into that in a Q&A if you're interested. And then crucially, anxiety. And I think that's related to the idea that people who are most stringent and are going through every possible precaution to avoid gluten are more likely to heal, but this might be a cause or an outcome of anxiety. And there are consequences of hypervigilance. And that to me speaks to the unmet need with regard to treating celiac disease with the gluten-free diet, which can be very difficult for some people. I should also point out that we have a whole lot of studies where we look to see if healing versus ongoing intestinal damage was associated with various outcomes. And we found a lot of null papers. We have a lot of null papers, a lot of null outcomes. In other words, people with ongoing damage did not have an increased or decreased risk of psychiatric disorders, skin disorders, et cetera. Mortality overall, the studies showed no difference there. The rest are shown here. Again, these lines are almost all blue because almost all the data of mucosal healing comes from Sweden. I would say that on a research agenda is really, we need more studies from outside of Sweden so as to see how generalizable these studies are. The question is, should we confirm mucosal healing? Is it important to take that second biopsy, perhaps 2-3 years later? Well, one reason to do it is that there is an association between persistent villus atrophy and lymphoma and fracture. And there's no accurate non-invasive marker for mucosal healing. We do look at antibody tests and they can normalize over time, but there are people whose antibody tests normalize and yet have ongoing damage. And so that's one reason why we at Columbia, at least, we advocate doing a second biopsy. And I certainly engage in shared decision-making with my patients about this. Why might one not opt for a second biopsy? Well, it's not associated with mortality. People with ongoing damage seem to live just as long as people with healing. These studies, all of them, I've been involved in a number of them, but I have to admit, these are not the highest quality studies because they're observational. They're not randomized trials. And who gets a biopsy and why someone gets a biopsy is not something we have control of in these studies. They might be very different from people who don't get a biopsy. People who heal might be very different from people who don't heal in many ways, and maybe that's driving some of these differences. And then really the biggest question, and my colleague Dan Leffler up in Boston, he's made this argument: will the result change our management? We're telling someone to be strict, we're monitoring for symptoms. Will a result of a second biopsy change what we tell them to do? I believe that it might, because there's one thing I've learned in the community of celiac disease is that there's always someone stricter in terms of following the diet. There's always someone taking more precautions. But I've also learned that those extra precautions sometimes carry a cost, particularly in terms of quality of life. And so I believe that doing a biopsy and seeing if someone's healed can be helpful, because if they've healed, I tell patients, your current precautions are sufficient. You're doing what you have to do. People with this outcome have the best long-term outcome with regard to cancer risk. They no longer have an increased lymphoma risk. And you don't necessarily have to up your game with regard to the additional precautions that someone in your peer group or on an online forum is doing. So I think it can be helpful, but this really is a matter of shared decision making. A couple more briefly. So in patients with newly diagnosed celiac disease, what is the effect of the gluten-free diet without oats on increasing your rate of remission and mucosal healing compared to oats? What do we do about oats? Now, there's a loaded question if I ever heard one. This is a moving target, of course. I'd point out that oats, we believe, should cause less of an issue in terms of our immune system in celiac disease, fundamentally because they are a more distant cousin in the phylogenetic tree. If you look at the Avenin family, the oats, this genus rather, they are separate from wheat, rye, and barley that are in the Triticae tribe, right? And so you would think that because it is less closely related to these other grains, it should have a distinct, perhaps protected, non-toxic effect in people with celiac disease. There are reasons that we might want to encourage oats. It makes the diet easier to tolerate, more palatable for many people. It's got beneficial nutrients, it's got fiber, it helps people move their bowels. But there are issues. A lot of oats are grown and harvested in such a way where it comes into contact with wheat, rye, and barley, gluten. And it's also been shown that avenin protein in oats can trigger immune reaction in some people. Now, it says here rare. We're less sure about how rare that really is in recent studies, but it can be immunogenic for some people. And it could be that certain oats are more toxic than others. And if someone's eating oats, we may need to monitor them, make sure that they are tolerating it. There have been a number of studies that have come out since the last guidelines. One is a systematic review and meta-analysis by Pinto Sanchez and colleagues under the auspices of the Society for the Study of Celiac Disease, the SSCD. And basically it found that there was no effect of oats on symptoms, histology, serology. But these studies, the inputs into that systematic review were limited by the fact that the type and quantity of oats were not specified, and very few were actually randomized trials. The second study coming out of Finland found that there was no difference in adherence, symptoms, blood tests, histology, long-term risks, and overall, those who were eating oats just reported better overall health. Finally, a study out of Italy was a randomized placebo-controlled trial, and it found no significant oat effect on clinical symptoms, blood tests, intestinal permeability. So in general, the literature seems to bear out that oats are well tolerated. And yet we know that some oats are contaminated with gluten. And we know that in some people it's immunogenic. And so we recommend here that oats, gluten-free oats, can be consumed as part of a gluten-free diet, but that they require monitoring for oat tolerance due to gluten contamination, variable toxicity in different variety of oats, and a small risk for an immune reaction to avena in oats. In the document, we elaborate further about the idea that it's likely safe for most, but not everyone, and it may be immunogenic, it might stimulate the immune system. And the tolerance might be related to the origin of harvesting and quantity consumed. It might be that you can tolerate a certain amount of oats, but it's unknown how often to monitor for symptoms and antibodies. So there's a huge research gap here, and it really should be on our research agenda. Studying oats, when should they be introduced? Should they be recommended for everyone, and how to monitor people when they're eating oats? The final one that I'm going to recommend before we go, or review before we go to some closing remarks and then Q&A, is for patients with celiac disease, does the use of pneumococcal vaccine reduce the future risk of serious pneumococcal infection compared to no pneumococcal vaccine? So Streptococcus pneumonia is an important cause of community-acquired pneumonia in the general population. And it turns out that this kind of pneumonia, pneumococcal pneumonia, is more likely to happen in people with celiac disease, both adults and children. And that's probably related to low spleen function, hyposplenism, that has been found in up to 1/3 of those with celiac disease. So there was a systematic review and meta-analysis, again, a study of studies performed by Simons and colleagues, and my mentor, Peter Green at Columbia, was involved with this. They found that when collecting all the studies of this risk, they found a 2-fold increased risk of this kind of infection in people with celiac disease compared to the general population. So the recommendation, this is a conditional recommendation with a low quality of evidence, is that we suggest vaccination to prevent pneumococcal disease. The key concept is this is a safe and effective vaccine. It's already recommended the general population without celiac disease in children younger than 2 and adults greater than 65, people who smoke. What we don't know is whether the vaccine is effective in those with celiac disease who have a very low splenic function. So, there's an unknown there. And the reason this is not a strong recommendation is there's never been a randomized trial that compares vaccination versus non-vaccination in people with celiac disease who are otherwise young and healthy. People who are not 65, who otherwise, if it weren't for their celiac disease, would never have gotten that vaccine. Does getting that extra vaccine prevent pneumonia? And how many cases of pneumonia are prevented per, whatever number of thousands of people with celiac disease get that vaccine? Because those data are just not known, all we can say is it stands to reason that this safe vaccine would be effective in people with celiac disease, and they should be considered a group at moderately increased risk, and so we can recommend it. Before we go to Q&A, I just want to point out that this document this new set of guidelines issued by the ACG comes with it a number of diagnostic algorithms and lists that might be useful for the provider taking care of people with celiac disease. Shown here is figure 1 from this set of guidelines, and it's really busy, but I just want to point out some highlights. So for one is this is, how to make the diagnosis of celiac disease. And you can see the first branch point after clinical suspicion is, well, what is the patient eating right now? We often assume, oh, someone comes and they want to get checked for celiac disease. Right now they're eating gluten, but no, not everyone's on a normal or gluten-containing diet. Some people are already on a gluten-free diet at the time of initial assessment. So this algorithm takes you through how to deal with that. And there's a role for HLA testing, genetic testing, because if it's negative, it makes celiac disease extremely unlikely. And then it goes through how to test for celiac disease. And if the TTG-IgA is positive, they actually talk about the non-biopsy criteria for the first time. And that's mentioned in this algorithm. This algorithm also helps the user go over the potential causes of people who have villus atrophy on their small intestine, but who have normal celiac antibodies. And there's a list, and I actually go over some of them: the drug olmesartan, CVID, which is common variable immunodeficiency, and other causes. So this I thought was handy. There's also like a handy algorithm on how to monitor celiac disease. This is just based on expert opinion, the opinions of the authors. This is not part of the whole grade process with PICO questions, and does not have that kind of rigor that involved the literature search. This was a bunch of us, like sort of in the old tradition, getting together and saying, oh, what do you do? This is what I do. And it shows how you might monitor someone with celiac disease after diagnosis. They talk about what should be tested for or looked at 3 to 6 months after the initial diagnosis, what to do if they're not responding, what to do if they are responding, what to do in follow-up, and how often to follow up. So again, it's all part of this one document that you might find handy. And then there's also included, and this is really lifted from the older guideline, it's really unchanged, an algorithm for what to do with someone with celiac disease who has ongoing symptoms, so-called non-responsive celiac disease, and it goes through the checklist. So that's also included in these guidelines. So we really wanted to make this, not the be-all and end-all, but a very convenient reference document for people who are interested in taking care of those with celiac disease. Before we open it up, I just want to offer a few concluding thoughts. These guidelines are an update. These were not composed from scratch. This is an update from the 2013 guidelines, and we build upon that. We don't choose every clinically relevant question in celiac disease. We chose those questions which we thought the new literature in the last 10 years may have moved the needle on, hence the recommendations on diagnosis, and in some cases without a biopsy. The changes in recommendations are incremental. We're making a very modest step away from a biopsy in only certain situations and conditions. And these recommendations may change based on the emergence of more data. We're hopefully going to learn more about what the true positive predictive value of highly elevated tissue transglutaminase is in adults, particularly United States and Canada. We'll also likely learn more about laboratory variability and quality issues that, we have so much data from Europe, but we have less data from this hemisphere. And so will that affect our recommendations? So these could change. And then the last thing I'd say is these are guidelines. They're just that. They're ways to sort of nudge you in a certain direction. They are not commandments. Not adhering to guidelines is not medical malpractice. There are reasons someone might not adhere to guidelines. And individualizing someone's case is often a sign of good medicine, actually. But the reason these guidelines exist is so as to sort of center people in terms of, well, what's the norm? And if you're deviating from the norm or you're not adhering to the guideline, why? What is it about this individual case that makes you not adhere to this guideline? And you can disagree with the guidelines. You might say they're premature. You might say they haven't gone far enough. And we've certainly heard this from both sides. But again, this is not Mosaic law. This is not the 10 Commandments. This really is just one way of looking at things. And we encourage patients and their practitioners to incorporate this into their practice. And if they're not adhering strictly to any of them, to try to justify and say, this is why. So I would just conclude with this. Again, the link is on the bottom of the screen and the QR code's on the top. And with that, I thank you for your attention, and I look forward to the Q&A.
Thank you so much, Dr. Lebwohl. That was fascinating. And I'm already thinking about a part 2 because I want to hear the other 4 PICO questions. But we'll get to our questions from our audience. And the first one is, can a child be seronegative? Could they be missed by avoiding a biopsy?
Well, if a child is seronegative, if they get blood tests and the blood tests are negative, does that child definitely not have celiac disease? And anyone who tests negative for celiac disease, if they test negative on blood work, it is highly unlikely that they have celiac disease, highly unlikely. But we don't say that their chance is 0. There are a few, important caveats. First of all, there's certain populations where serologies are much less reliable. Children under 2, can't rely on that. Children with selective IgA deficiency, you can't rely on the TTG IgA. You need to look at IgG serologies. Even beyond those populations, there's a small subset of people with celiac disease who have so-called seronegative celiac disease. They have it on a biopsy and it doesn't show up in the blood. And so, the decision to go ahead with a biopsy, even in the face of negative serologies, we sometimes do that. We do that if our suspicion is at least moderate or high. Take a child who's failing to thrive, has multiple signs and symptoms, and they have a family history of celiac disease, then you might go straight to a biopsy, even if the blood tests are negative. That said, in an average risk individual, someone who feels fine, but their mom's got celiac, or someone with a diagnosis that appears to be an irritable bowel syndrome, generally we rely on serologies alone because their negative predictive value is really excellent. And if they're negative, it's very unlikely that they have celiac disease.
Okay, thank you. Okay, the next question is, can you speak more about hyposplenism being found in 1/3 of those with celiac disease, and how do you suspect or test for this?
Well, that study diagnosed hyposplenism in a very crude way, basically doing a blood test and doing a smear of the red blood and then looking under the microscope and seeing certain signs of hyposplenism based on the appearance of red blood cells. Typically, the spleen is in charge of clearing out sort of blood cells with any sort of minor defects on their surface. And if your spleen isn't functioning properly, you'll probably see more of these minor defects. They're not of consequence, these defects, but it's a sign that the spleen is sort of snoozing on the job. And so that study was based on the fact that, a very large percentage, up to 1/3 of people with celiac disease, they have those signs. Does that mean that those people with celiac disease are at higher risk of pneumococcal infection? Not necessarily, but we do know that if you take full populations of people with celiac disease, their rate of pneumococcal infection is higher than that of the general population. It stands to reason it's related to that notion of hyposplenism. We do not have a test in clinical practice that we regularly employ to see if an individual has hyposplenism. But certainly if anyone's had pneumonia like that, they should be vaccinated. And it's reasonable to ask for this vaccine if you've got celiac disease, even if you haven't had pneumonia and you're not in one of those higher risk age categories.
Okay. If a person needs to wait 9 months, this kind of question comes up all the time, so you'll be speaking to many. If a person needs to wait 9 months for an endoscopy, should they consume gluten for the entire 9 months? I guess the other part to this question is, or should they go gluten-free and do a gluten challenge before the test?
I think it's a good question. So that really depends on the individual circumstance. If someone is suffering with a lot of symptoms, they're not even going to ask me. They think they've probably got celiac disease. They want to feel better yesterday. They're going to start the gluten-free diet. So certainly if someone's having major symptoms, if someone is totally asymptomatic and they got screened for celiac disease because their mom's got it, or some other, I would say, relatively weak indication, maybe a mild iron deficiency that's not causing symptoms, then staying on a gluten-containing diet until you're sure you've got celiac disease is perfectly reasonable. So, many people are not comfortable with such a long wait, and I'm not sure what the local situation is. Certainly, when this comes up in the United States, we really try to prioritize people like in this situation and say, look, the clock is ticking. We don't want them to go gluten-free and then make it a more confusing diagnostic situation. Let's see. I mean, what we typically do is we wait for cancellations and we put them on lists. We get cancellations all the time, and then we try to get people up. And we tell our patients also, be a squeaky wheel, like remind the doc, any cancellations next week, doc? So we really encourage people to do that. I don't know if it works like that in Canada.
Oh, it does. Yeah. Squeaky wheels.
Yeah, okay. I thought
We
maybe
talk about that too.
thought it was maybe just a New York thing. But
No, it's a Canadian thing too.
so yeah,
Um,
so I encourage people to try to get the proper diagnosis. In some cases, it's just not practical. In a pregnant patient, I don't want them to keep eating gluten for another 8 months, if it's discovered.
Yeah.
So I say go gluten-free now, and then let's worry about it later. And sometimes that does involve a gluten challenge later.
Okay. What would be the reason that North American testing isn't the same as European testing? So I guess NASPGHAN versus ESPGHAN.
Yeah,
Why is it different?
So the only reason to wonder about that is that it's just a different set of companies. So, just like, automobiles or any major, set of commercial entities, it could very well be that the set of labs that are most popularly used in the United States have a performance characteristic. They're not going to be wildly different, but in this one situation, 1 or 2 percentage points makes a big difference. Are we talking 95% sure or 99% sure? So we really want to know, using the US sets of labs, are we closer to 99%?
Okay. Okay, this is a question. I've actually heard you speak on this topic on another presentation, but where can I find the current recommendations on starting solids with gluten for infants in a mother
Yeah.
with celiac disease?
So, there are recommendations that have been issued by NASPGHAN, the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. And they talk about gluten timing and amount of gluten introduction. This really is a topic in and of itself. But, what I would say on one foot, the short version is this. We used to be much more sure about exactly how to optimize, prevent celiac disease with introducing gluten in a certain narrow window during months 4, 5, and 6 of life of infancy. And then subsequent studies have disproven that notion and made us more uncertain and sort of humble about what to recommend. Now it appears the only thing that we're fairly sure of is that prolonged delay of gluten introduction beyond 1 year is probably not a good idea. And so what NASPGHAN and others recommend is that you should do it at around that time and not to delay it beyond that time. There's also emerging studies that suggest that hitting someone hard with a large amount of gluten the first time or the first few weeks, it might potentially increase the risk of celiac disease. And so low, cautious introduction is advisable. But, speak about this also with your pediatrician or pediatric GI and take a look at those guidelines. You're also welcome to check out a talk on Celiac Connect, which if you go to the Celiac Disease Center at Columbia University's website, if you just Google Celiac Columbia, you can find this series of sessions. And one of them is about this very topic about how to prevent celiac disease and infant feeding practices.
Yeah, it was a fabulous one. Okay, somebody is asking about breast cancer risk with celiac disease. So with stable versus, I guess, either undiagnosed or not well treated.
Yeah. So celiac disease is associated with a small but significant increased risk of certain cancers. The most prominent ones are lymphoma, and mostly non-Hodgkin's lymphoma and small intestinal cancer. But paradoxically, it is associated with a decreased risk of lung cancer and breast cancer. Both of those cancers are less common in people with celiac disease. And these appear to be the case both among people after they get diagnosed with celiac disease and also before. The reasons are unknown. And most of the studies that looked at this lacked information on several crucial other risk factors. For breast cancer, a really important one is body mass index, one's weight as a relation to their height, because higher body mass index is associated with an increased risk of breast cancer. People with especially undiagnosed celiac disease or celiac disease that doesn't heal, they tend to have lower body mass indices, they weigh less. It could be that it's something as simple as that that's causing this decreased risk of breast cancer. It could be that there's something in the diet or some nutrient that's not being absorbed because of active celiac disease. And that thing, whatever it is a minor risk factor for breast cancer. So, this is not actionable data. It's somewhat a curiosity, and it does lead us to, want to study this more and try to understand what is it that's decreasing the risk of breast cancer and celiac disease. But the data are the data. I mean, multiple studies have shown this, so I think it is real.
Interesting. Okay, can you speak to us? I know that this would be this is a chunk of time as well, but the gluten detection devices question
Sure.
from the PICO questions. What can you tell us about that?
So, this was one of the, newer questions that came up. What I'd say the upshot is, the recommendation was we suggest against routine use of gluten detection devices in food or biospecimens among patients with celiac disease. So that's the short answer. A little commentary on that. We don't say we recommend against. We're not that confident. We suggest against. It's a weak recommendation. And we don't say don't use them. We suggest against routine use. In other words, we are saying they're not for everyone. We're not going to sort of say everyone should be using these. We think that routine use, it's premature. There's not enough data to support their use. I would say that there are some very preliminary promising data that suggests that both the detection devices in food might be particularly helpful for certain kinds of patients with celiac disease who are navigating the diet when eating out. And the stool and urine detection devices to monitor people for suspected gluten exposure. These devices really do measure gluten. None of them are perfect, and none measure every form of gluten, and all have a certain degree of pitfalls, both in terms of false negatives in all of these, and then for the NEMA detection device, false positives, and by that I mean finding gluten when there's such a negligibly small amount of gluten, it might not be relevant. So what do we do with that? We don't know yet. And we at Columbia and others are really eager to study this because I do think there's potential there. But for now, the consensus was we suggest against the routine use, but more to come.
Okay. I know we get that question often as well. People are asking, and I'm going to kind of generalize this question for somebody with a family member with a first degree family member with celiac disease, genetically related, how often should they be screened for celiac disease?
That's a good question. It's not one that we formally tackled in this set of guidelines. We do touch upon it in the question of, who should be tested. And the whole topic of testing family members is one that's fraught with uncertainty and even controversy, because some people say, well, if the family member feels fine, why even test them? Most people in the celiac disease community, myself included, believe that there is value in testing even someone who has no symptoms, because celiac disease can cause major problems before any symptoms become apparent. And certainly if there is a first degree relative, it's an enriched population, they're more likely to get celiac disease, maybe a lifetime risk of about 10%. The question of how often to test is, again, uncertain. The traditional teaching had been, well, check their genes, and if they have DQ2 or DQ8, then you should check them every so often. What that means, I would say up until recently, we said every 3 to 5 years. And that's the short answer. I should say there was a very recent study coming out of Europe that suggested that if you look at the specific number of genes and you look at how many relatives the child has, and you look at how old the child is now, you can actually have a more refined sense of what their risk is in the next few years. And based on that, you might get tested more frequently. There's actually a recent paper published in the journal Gastroenterology, and it even links to an online calculator that the doctor can say, all right, how many relatives, you put in all this, and then it says, we suggest you test every so often.
Yeah, I checked that out. It was very interesting. Okay, so on that note, the next question related to that is, for somebody diagnosed with celiac disease, how often should they have their TTG tested as management?
So TTG use as management is one that, that was never the intended initial effect when those tests were discovered, but it turns out that they tend to come down after adoption of a gluten-free diet. There's no evidence base to how to do this. The best I can do is I can tell you what I do. And I do this based on my own experience. I sort of learned it from my mentors, and many of the people in the celiac world do something similar, which is after the initial diagnosis, check it again every, say, 3 to 4 months in the beginning, which translates to 3 or 4 times over the course of the year. Some people do it less, maybe 6 months, just to make sure it's coming down. At 1 year, most people have normalized or have a nearly normal level. And once it normalizes, check it once a year. If it hasn't yet normalized, keep checking it every 3 to 4 months, make sure it's still coming down. If it stops coming down, or if it starts to inch back up, that is a red flag of the possibility of ongoing inadvertent gluten exposure. Not always. And particularly some patients, they start with a really high level and then it comes down, but it's not quite normal. It's like a little bit normal in that it's still got that red flag on it. And the significance of that is unclear, but most of the time, if the patient feels well and it just stays like that for a long time, when I do a biopsy, it's normal. And I say, don't worry about it. But
Okay.
that's the frequency with which I follow it.
Okay, that's interesting. Okay, so the PICO question number 4, I'm being asked to ask about, which is probiotics and the gluten-free diet as part of healing.
Sure. So the answer or the recommendation we said was, we sort of punted. We said there is insufficient evidence to recommend for or against the use of probiotics in a treatment of celiac disease. And I know that's sort of a downer. It's like we're saying we don't know, but that's what the data are suggesting. There have been a couple of potentially promising studies that suggest in children, if you give them probiotics after diagnosis, they might heal more completely or more quickly than people who get placebo. So some high quality studies showed that, but not all studies showed that. So because of the inconsistency of the data, and because there are very few high quality studies, and because on top of that, the sort of quality control for probiotics in the United States, at least, is poor, because they tend to be poorly regulated or regulated under a very lax framework because they're marketed as supplements. So you're never quite sure what's actually inside the thing you're taking. For that, we said there's insufficient evidence. We didn't recommend against because there are some promising studies that suggest that maybe it's helpful. I personally don't push these. There's just too much uncertainty about their content and regulation. But if a patient finds that it makes them feel better and they're doing well and they've healed, I say, great, continue it.
Awesome. Okay, 2 more questions. And this is an interesting one. And I'm curious, why is celiac disease more prevalent now? Is it because of advanced testing? Is there more awareness, or are we actually seeing an increase in numbers?
So great question. The answer is yes to both. There is definitely more testing, and certainly someone who might have gone undiagnosed in 1990 would now be tested more readily, at least by many practitioners, because of the increased awareness. But we also know that it's not just that. There's more celiac disease now than there was a generation ago. We know this because of studies that looked at frozen blood samples from the 1950s that then got thawed and tested for the celiac disease antibodies. And those blood samples had very low levels of celiac antibodies, nearly as common as they are now. Why it's more common now, why there's more celiac now, is a big mystery. I think that the hygiene hypothesis is probably correct, which is that our relationship to germs has changed. We're exposed to fewer germs and more antibiotics, especially early in life, than we used to be generations ago. And that's probably had an effect on our immune system, making us more prone to various autoimmune problems, including celiac disease. But it's just a theory.
Interesting. Okay, final question. As a music major, what is your favorite composer and your favorite song?
That's an easy one. So at least for composer, it's Beethoven. Beethoven was someone who struggled with illness and disability his whole life. And he eventually became public about that. He had to. He was losing his hearing. It was part of the heart of his profession. And he really was brought to despair because of this. And then he managed to somehow, listen to his inner voice and create such amazing art and be an inspiration, really to himself, but really to the world around him and to subsequent generations. I would say that his Ninth Symphony is seen as sort of a national anthem, but for the whole world. And to think about someone who was struggling with isolation and deafness his whole life, and had a very difficult life in childhood, to have such a positive outlook, to me, is very inspiring.
Amazing. I'm going to have to look up the Ninth Symphony. Well, thank you so much for joining us tonight. This has been absolutely educational for me and for our audience. So thank you so much. We look forward to having you back again if you'll come back another time. So thank you to Dr. Ben Lebwohl from Columbia University for joining us here tonight. As this is our last webinar Wednesday during Celiac Awareness Month, I want to wish Celiac Canada a very happy 50th birthday and wish everybody who joined us here tonight a very happy Celiac Awareness Month as we wrap up on this 31st and move into June tomorrow. So thank you everyone for joining us. Please check out Celiac Canada on our website, www.celiac.ca. Of course, to donate, we are a charity, or to look for our resources. And for all of you joining us here this evening, you will be getting a follow-up email, including the link to this webinar, which will be on our YouTube channel. Thanks everyone so much. We will see you next time. Thanks, Dr. Lebwohl.